speaker, Srikanth Srinivasan, who's going to talk to us about the impact of revised Starling hypothesis on clinical practice. So Dr. Srinivasan is head of the Department of Critical Care in Manipal Hospital, New Delhi, India. And his area of interest is point of care ultrasound, extracorporeal membrane oxygenation, and is also associate editor of the Indian Journal of Critical Care Medicine and authored the textbook on point of care ultrasound, and is also joint secretary of the Indian Society of Critical Care Medicine. So please, Dr. Srinivasan, let's tell us more about the impact of revised Starling hypothesis on clinical practice.
Okay, thank you, Professor Malbrain, for that kind introduction. And without wasting more time, I'll just go ahead with the topic which has been assigned to me. Dr. Saurabh, could you just allow me to share my screen, please? Dr. Saurabh, the host has to allow me to share my screen. Right. So you can see my screen? Yes?
Yes, we can.
Yes. Okay. So at the outset, I'd like to thank Dr. Saurabh and the Artemis Critical Care Group for inviting me to speak about this topic. The topic allotted to me is impact of revised Starling hypothesis or revised Starling principle on clinical practice. We know that Ernst Starling in 1896 transfused some amount of fluid into the hind limb of a dog, and then he realized that that fluid got absorbed. So he postulated that obviously the capillaries and the venous end of the system probably is semi-permeable, and based on hydrostatic pressure differences and oncotic pressure differences, the fluid can be reabsorbed. Over the years, what we have realized that this principle, although forms the foundation of the idea of fluid exchange across semi-permeable membranes as seen in the capillaries, but still does not go ahead to explain a lot of things which have been found in clinical trials. For example, why there isn't much of a difference in volume expansion capacities vis-a-vis colloids versus crystalloids. And does albumin actually draw fluid from the interstitium or not? So these are a few questions which I'll try to answer. And for this very reason, a revised Starling hypothesis was brought into the picture. And as the understanding about the filtration across the endothelium increased, especially the role of the endothelial glycocalyx membrane, which is called the EGL. So that plays a pivotal role in ultrafiltration across the endothelium, and that has sort of brought about a change in the paradigm. And that's brought about what's called the revised Starling hypothesis. It will not be correct to sort of call it revised, rather the word should be extended, because we still are leaning upon what was postulated by Starling in 1896, right? The basic principles remain the same, that there is an hydrostatic pressure difference between the capillaries and the interstitia, and there's an oncotic pressure difference, which is the opposing force to the fluid leaking out of capillaries. Right. So the Starling principle founded the foundation or the backbone for explaining a lot of phenomena. How do we maintain the tissue fluid balance? How the plasma volume is maintained, how it's distributed between the intracellular, the extracellular, and the interstitial compartments? What is the foundation of edema or the cause of edema? And he postulated that the fluid movement depends on the net imbalance between the capillary hydraulic pressure and the colloid osmotic pressure. So if you want to put it in a mathematical or a clinical model, so we can see that at the arteriolar end, the pressure, the hydrostatic pressure within the capillary is around 25 to 35 millimeter mercury. And this pressure gradually falls through the capillaries towards the venial end towards something around 12 to 15 or 12 to 16 millimeter mercury. This is the pressure which is exerted by the blood within the capillaries, and this causes a net outward pressure. It's hydrostatic pressure, it's a net outward pressure. This net outward pressure is counterbalanced by a baseline osmotic pressure, which is basically attributed to albumin, which is there within our blood, within the plasma. And that oncotic pressure is around 25 millimeter of mercury, which is static throughout the capillary from the length from the arterial to the venous side. So what Starling postulated was, as the filtration predominates towards the arterial end, where the hydrostatic pressure is more than the oncotic pressure, at some point towards the venous end, the oncotic pressure becomes more than the hydrostatic pressure, and hence there will be a net reabsorption of fluid or reversal of fluid from the interstitia into the capillaries. So this is the formula which comes across. The net filtration is also established by the word JV. The formula is K, which is the filtration coefficient across the membrane, which depends on the hydraulic porosity of the membrane multiplied by surface area of the membrane, and the differential between the hydrostatic pressure within the capillaries vis-a-vis within the interstitia, that is PC and PI, minus what is the difference in the oncotic pressures between the capillaries and the interstitia. Later on, over a period of time, it was realized that most of the capillaries, since capillaries are semi-permeable, so the amount of oncotic difference, pressure difference, and albumin is permeable from between the capillaries to the interstitia, and in fact, 40% of the albumin is within the vessels and 60% is outside in the interstitia. So it was realized that there is some amount of leakiness of albumin in the interstitia. So there was one more term which was added to this equation. It's called the Staverman's osmotic reflection coefficient, or sigma, which is basically, in effect, the porosity or the permeability of the membrane of the endothelium to albumin. So effectively, the forces opposing filtration, or the forces which will stop the net filtration from going out of the capillaries, was also denominated as PCO, is dependent on the differential of the oncotic pressures and the interstitial pressure within the interstitium. So as per Starling, there should be filtration at the arterial end, and at some level, there will be some kind of an equilibrium where the oncotic pressure will predominate and there will be a net reabsorption. But there were certain problems to this baseline theory which was given. First of all, at that level, that stage of time, the interstitial oncotic pressure could not be measured, right? But as with newer advances, when we started measuring the interstitial oncotic pressure, it was found to be very high. It was found to be around 16 millimeter mercury. So that is one problem which is there. Remind you, the interstitial oncotic pressure is something which allows the fluid to draw from the capillary into the interstitium. So that is a net filtration force. So that is found to be very high. Secondly, if it is high, the net driving force, also called the PCO, since it is dependent on the high interstitial pressure, that means the net movement of fluid is always outwards. It's always from the capillary to the interstitium. Since the interstitial pressure is high, the drawing force is high. The capillary pressure is higher than the oncotic pressure. So invariably, the driving force should be always high throughout the length of the capillaries, either from the arterial to the venular end. So there should be a constant state of filtration and no reabsorption. So the idea of a Starling equilibrium probably does not exist. So this principle was challenged by Levick and all in 1991, which said that there is a constant filtration from the arterial end to a venular end, which gradually falls as the hydrostatic pressure falls. But there is never a reversal or a reabsorption of fluid back into the capillaries from the venular end. So this is in a steady state condition. There's always a net filtration force. So there is definitely never a true Starling equilibrium, and there's always a net filtration. But the problem is, if there is no reabsorption from the venular end, then in that case, there should be a very large amount of filtration which is occurring. And if all the filtered fluid is not being reabsorbed by the veins, then it's probably being cleared by the lymphatics. But what we have seen is that the lymphatic flow does not actually match what should be the classical amount of fluid which is being filtered out from the capillaries based on the Starling equation which has been given. So there is a discrepancy between the amount of fluid which is filtered out and the lymphatic flow. So here comes in the role of the endothelial glycocalyx layer, which is on the luminal surface of the endothelial membrane. And this is the predominant molecular sieve which plays a major role in ultrafiltration. And that is the understanding which has come in over the period of time. So it is across the glycocalyx that the oncotic pressure difference is exerted. It is not plasma oncotic pressure minus interstitial oncotic pressure. Rather, it's a plasma oncotic pressure minus the subglycocalyx interstitial oncotic pressure. So that is where the difference falls rather than between the plasma and the interstitial. Right? So it's the colloid oncotic pressure differential is no longer a transendothelial force, rather it's an intraendothelial force. So if you rearrange the entire equation, instead of pi c minus pi I, which is interstitium, it becomes pi subglycocalyx. And the pi subglycocalyx is very, very low. So if you see it as a model, you have the lumen and you have a thick layer of gel, which is the glycocalyx. And it is across this glycocalyx that the colloid oncotic pressure exists. Now, mind you, since the pi Sg is very low, the entire driving force of filtration is predominantly dependent on the capillary hydrostatic pressure, the pi c. So this is the predominant driving force which will drive the fluid across the capillaries. And the oncotic pressures rather play a very small role. So this is a difference between the classical model, which is now known to be inaccurate, and the current glycocalyx model, which says that the glycocalyx will disrupt the oncotic pressure gradient. The oncotic pressure has some role, but not a major role. And it is the difference between the plasma oncotic pressure and the subglycocalyx oncotic pressure, which opposes the net filtration across the membrane. And almost 100% of the interstitial fluid, which is filtered out, has to be cleared by lymphatics. So it says that lymphatics play the predominant role in clearing of fluid from the interstitium. It is not reabsorption into the veins. So this again puts us into a new perspective that how much is the distribution of colloid crystalloids? This is a classical thing which we have been taught all along, that the colloid probably stays within the intravascular space and the crystalloid redistributes across the entire interstitium and the intravascular. This is not found to be true. Rather, the volume of distribution of colloid and crystalloid is not much different. The crystalloid having a larger volume of distribution, obviously, it redistributes not only into the intravascular space, into the plasma, but also into the intravascular space, which comprises of the endothelial glycocalyx layer as well. So the endothelial glycocalyx layer is a gel form, which tends to absorb a large amount of fluid. And that gel form is what is the extra volume, which is occupied by the crystalloids when you give volume of crystalloids. This is how the endothelial glycocalyx looks like. And this is the glycocalyx model. It says that the glycocalyx layer is semi-permeable to proteins, and this causes a low oncotic pressure in the subglycocalyx area. The intravascular volume no longer comprises only of plasma volume and cells, rather it comprises of plasma volume, glycocalyx volume, and cells. And the transcapillary flow, as I just mentioned, is driven by a hydrostatic gradient, difference in the oncotic pressure between the plasma and the subglycocalyx space, and not in the interstitial space. So if you were to look at it by a more detailed kind of a model, if you see this, we have a glycocalyx layer, we have the endothelial cells, and the difference in the oncotic pressure between the plasma and the subglycocalyx is what is the net oncotic pressure differential, which is countering our forward filtration. So, as I mentioned before, the predominant force of filtration is the capillary hydrostatic pressure, and the oncotic pressure difference only serves to retard the filtration. But mind you, this kind of pattern or this kind of endothelia doesn't exist everywhere in the body. Definitely is the most common form of endothelia which is there, which is present in the nervous system, muscle connective tissue, and the lungs. So this is a major part of the endothelia which is there in the body, but we have different forms. We have in fact 4 phenotypes of capillaries. Some of them have very, very fenestrated capillaries, very less amount of glycocalyx, for example, the sinusoidal areas in the liver and spleen, where there is no difference between the intracellular and the extravascular space. They are all in continuity from each other. So there is no difference between anything at all. The intracellular space and the interstitial fluid, they are all mixed together. Similarly, there are fenestrated capillaries in the gut mucosa, the endocrine, the choroid plexus, and in the glomeruli, where there's again break in the glycocalyx layer. So these are different kind of endothelia, but short of that, the major part of the endothelium lining is comprised of non-fenestrated capillaries. So the question is, does reabsorption ever occur? Yes, it does. So it does, but it occurs very, very transiently. And when does that occur? is when there is an acute sudden reduction of the transendothelial pressure difference. For example, if there's a sudden catastrophic fall in the capillary hydrostatic pressure, either because of precapillary vasoconstriction, postcapillary vasodilatation, or hypovolemia, so there could be a transient reabsorption up to a level of 500 ml. Now, when this reabsorption occurs, this reabsorption is postulated to occur because of movement of fluid from the endothelial glycocalyx gel back into the circulation, rather than moving of fluid from the interstitium into the circulation. So that is what has been postulated, that the volume of gel which is there in the glycocalyx is what is being transferred intraluminally or into the vessels. And this is around 500 ml. This transient because what happens is once the glycocalyx layer starts to dehydrate, there is leakage of proteins from the interstitial fluid into the subglycocalyx, and the oncotic pressure of the subglycocalyx space, which was very, very minimal, becomes high. When the oncotic pressure of the subglycocalyx space becomes high, that forms a drawing force again, and it balances. It comes to a new kind of a baseline after a few minutes, and from there it reaches again a steady state filtration kind of mode. So this is what has been observed, that the glycocalyx model operates to preserve filtration and prevent reabsorption. So if you can see that the curve which is available, it's like a J. So it's over a large range of capillary pressures. It's almost just above zero. So in a very low rate of filtration goes on. Once the capillary pressure overcomes the oncotic pressure, which is the retarding force, there's a rapid increase in the filtration of fluid. So this J point concept is important in two ways. Below the J point, the filtration is very, very negligible. So irrespective of whether we give colloids or crystalloids, they are both going to remain within the vascular compartment. So there is no difference between colloids and crystalloids up to the J point. So at low levels of capillary pressure, colloid crystalloids probably will have the same volume expanding effect. It's only when you cross the J point, that is when the capillary pressure really overshoots the oncotic pressure within the vessels, is when we start having filtration outwards. Similarly, if you further go on with the J point idea, as long as the J point is further moved towards the right, as it occurs when the capillary interstitial hydrostatic pressure increases in the form of edema, or the oncotic pressure of the capillaries increase, then the J point is increased further. So the tendency to keep the fluid within the circulation is much more. The J point moves towards the left because the capillaries become more leakier, especially in inflammatory conditions. When there's an inflammatory condition, there is loss of the glycocalyx layer. So the capillaries become more porous, more leaky, and the J point moves towards the left. So very rapid leakiness of capillaries to both crystalloids as well as colloids. So you can see that if this is the classical curve, once we give a massive bolus of crystalloids, which suddenly increases the capillary pressure by 10 millimeter mercury, so it ends up diluting the protein or the oncotic pressure within the capillaries, and that is going to lead to a sudden rise in filtration. And on the contrary, when the capillary pressure is low, irrespective of whether you give crystalloid and colloid, both are going to work equivalently and both are going to be retained for a longer period of time. For example, if the capillary pressure is only 12, then the retention of crystalloid in circulation is 80% at 40 minutes. But when it's normal, it's only 20%. So now coming to what is the implications for practice. First of all, let's talk about volume expansion by colloids. Now this principle, this mathematical model, experimental model, explains why there is little difference between the hemodynamic outcome, especially when regards to volume infused between crystalloids, between colloids and isotonic crystalloids. The key determinant we know is the PC minus PI, that is the net hydrostatic pressure difference, which is the driving force. And the colloid oncotic pressure is just a retardant force. Hence, the volume expansion effect of colloids are much lesser than what we expect or what we always thought used to be. In fact, when the patient is dehydrated, acutely dehydrated, there's a stronger argument for isotonic crystalloids, because these isotonic crystalloids will end up rehydrating the endothelial glycocalyx layer, because they are distributed not only within the intravascular compartment, but also into this gel layer of the endothelial glycocalyx. The next concept is fluids and edema in inflammatory states. Now, whenever there is inflammation, there is dilatation of the pre-arterial capillary arterioles that leads to increased hydrostatic pressure within the capillaries. There is changes in the characteristics of the interstitium. There is decreased hydrostatic pressure within the interstitium. So the difference, the PC minus PI becomes much more higher. So there's a net increase in the filtration force. So there's much more increased filtration of fluids. The surface area of filtration also increases. So does the conductivity or the hydrostatic conductivity, which is the K factor in that. So effectively, there is a net movement of fluid outwards. Fragmentation of the glycocalyx will further cause leakiness of the capillaries, increased transmission of protein molecules across the capillaries into the interstitia, which will draw in more fluid from the capillary to the interstitia. So hence, the inflammatory state per se will totally spoil the entire picture by increasing the hydrostatic pressure, decreasing the capillary oncotic pressure, increasing the interstitial capillary oncotic pressure. So the net movement of fluid becomes outwards. So the idea to reduce edema should be to keep the intrathoracic pressure low, or the CVP basically low, because ultimately all the fluid is going to be cleared by lymphatics. So if you want the lymphatics to go back to the great ways, you need to keep a lower pressure in the intrathoracic cavity so that there is a reversal or the return of flow from the extremities towards the center. What is the role of vasopressors in edema? Now, the vasopressors, as per this model, should have a role. If we have precapillary vasodilators, as we saw in the previous slide, precapillary vasodilators are going to cause edema. And this is a very common side effect of calcium channel blockers. We have seen ankle edema. We have seen a lot of times it's said one of the side effects is because the hydrostatic pressure of the capillary is increased because of precapillary vasodilatation. On the other hand, all our vasopressors, which are alpha-1 adrenergic agonists, what they do is they reduce the capillary hydrostatic pressure by causing precapillary arteriolar vasoconstriction. So the net effect is that they reduce the filtration force, and they can be an effective anti-edema therapy. So instead of that becomes the rationale behind giving vasopressors early rather than just continuing to giving fluid boluses. Because in an inflammatory state, as I said, as in sepsis and all, there's a lot of leakage into the capillaries. Through the capillaries, the filtration rate is increased. But if we start vasopressors at the same time, it will reduce the net filtration force and possibly act in reducing the amount of edema. This also is the rationale behind giving epinephrine for treatment of anaphylaxis and anaphylactic reactions. Now coming to the phenomenon of context sensitivity. So we have seen volume kinetic experiments, which shows that clearance of isotonic solution from the intravascular compartment is substantially lower when the patient is anesthetized versus patients who are non-anesthetized. So there is a difference in the way these things are cleared. Obviously, the mean arterial pressure is the most important determinant of distribution of isotonic solution. Lower the pressure, the slower is the clearance of crystalloid from the circulation. So from this adage, anesthesia causes vasodilation. Spinal anesthesia or regional anesthesia causes vasodilatation. So more vasodilatation, lesser mean arterial pressure, especially at level. So the crystalloids tend to stay in for a longer period of time. So that becomes the concept of co-loading of crystalloid solution during spinal anesthesia. So this is much more effective than preloading. So you can actually give spinal anesthesia, and as the dilatation occurs, you should load accordingly rather than give it prior. Also, since colloids can be superior to crystalloids for isovolumic hemodilution. Why? Because colloids predominantly stay within, because of their higher oncotic qualities, they tend to retain within the capillaries. If they want to retain within the capillaries, they tend to dilute or cause some kind of anemia, because they increase the capillary volume, they are diluting the blood. So if you want to produce isovolumic hemodilution, colloid therapy could be superior to crystalloid therapy. Now coming to the very important role of albumin. How does albumin play a role? So there is no role of hyperoncotic albumin to draw fluid from the interstitium, especially in septic and inflamed patient. Why? We do presume that an albumin bolus will raise the capillary pressure, obviously. And obviously, this is because the hyperoncotic effect of albumin is 4 times that of plasma. So on one hand, it is increasing the capillary pressure. On the other hand, it's increasing the oncotic pressure. But it is also purported that this increase in oncotic pressure will be so much that is going to draw in fluid from the interstitium. We know that in a steady state, this does not occur. Reabsorption does not occur in steady state. So irrespective of how much albumin we may be giving, it's not going to draw in fluid from the interstitium into the cells, into the endothelium. Rather, over a period of time with inflammation, the albumin is going to leak out from the circulation into the interstitium, further increasing the interstitial oncotic pressure and causing further filtration and further edema. So albumin will not be a very great idea for trying to draw out fluid from the. And this is exactly what was seen in the SAFE and CHEST trial, where they saw that there's only 1.3:1 ratio between saline and albumin volume, rather than 3:1 or 5:1, which we expect. We expect the colloid to have a 5:1 effect. So 1 ml of colloid is going to 5 ml of crystalloid, but that's not been so. It's only 1.3:1, 1.4:1. So, and besides, in infusing colloid to the patient who has a degraded endothelial glycocalyx, what's going to happen? Colloid is going to come out into the interstitium and further worsen tissue edema. Right. So what explains the transient improvement in oxygenation with albumin? What is basically what is postulated is that the plasma volume will increase because of dehydration of the endothelial glycocalyx layer rather than the reabsorption of interstitial fluid. And the transient improvement in oxygenation may actually reflect improved oxygen delivery to the tissue. And that increased oxygen delivery will lead to increased mixed venous oxygen saturation and decreased dead space perfusion. So it is not drawing of fluid from the interstitium, it's just dehydration of the endothelial glycocalyx layer, which is caused by albumin. So effectively, what we should look at albumin is a marker of disease severity and predictor of complication. But the treatment of hypoalbuminemia by giving hyperoncotic albumin has no clinical benefit, as is shown by this model. In ARDS patient with low albumin, it does not, albumin plus or minus diuretics will not produce any improvement in pulmonary edema. It's a negative fluid balance rather than a colloid oncotic pressure difference that improves the alveolar arterial oxygen tension in ARDS patient. So the major role is played by the diuretic rather than, which leads to a negative fluid balance rather than albumin per se. This model also shows that at supranormal capillary pressure, infusion of colloid solution will preserve the colloid plasma colloid oncotic pressure, will raise the capillary pressure, will increase the filtration. A similar infusion of isotonic salt solution will also raise the capillary pressure, but because it's going to dilute the albumin within the capillaries, it's going to lower the oncotic pressure. So the rise in filtration is much more as compared to a colloid solution. So effectively, if you do supranormal hydration, more than what is required, more crystalloids will leak out as compared to colloids. But eventually, even the colloids will leak out. At subnormal capillary pressure, both are equivalent, right? There is no difference between the volume expansion effect of crystalloid versus colloid. Now, this being a very interesting kind of theory still needs clinical validation, as is this article by Robert Hahn et al., who said that the steady state condition on which we are based on, that there is no absorption, reabsorption, steady state, does not exist in real life. The real life is very dynamic, minute-to-minute change in the vasomotion occurs. So this has to be shown or clinically validated in real. This so far is a lab model. It is a mathematical model, which can tend to answer a lot of questions which have been pertaining with regards to ultrafiltration of fluid across a membrane. So to conclude, fluid resuscitation studies require us to reappraise the basics. What we thought was absorption and filtration at one end, absorption at one end does not occur. It appears to be an improvement over the original Starling principle. The important feature, it explains why albumin or plasma substitute have no advantage over balanced salt solution when the transendothelial pressure difference is low. Filtered fluid will return to the circulation mostly by lymphatics. And that's where the importance of preserving lymphatic flow comes into the picture. And it is likely that this equation and the glycocalyx model is still work in progress. It will be modified and refined in the light of physiology and clinical trial evidence. So this is all that I have to offer. And thank you all for a patient hearing.
Thank you so much, Dr. Srinivasan. So I think we take the questions at the end of the session. So let's move on. So it's my pleasure to introduce the next speaker, which is Dr. Rajesh Mishra. He is consultant Department of Critical Care at the Artemis Hospital, Haryana in India, and his area of interest is the critical care nephrology and ECMO. So he will give a second lecture on fluid or vasopressor responsiveness. So what are we actually looking at in critically ill patients? Please, Dr. Mishra.
Thank you, Professor Malbrain, sir, and for giving me this opportunity to provide this section. And I just ask Dr. Saurabh to allow me to share my screen before wasting any time. Is my screen visible to everyone?
Yes, it is.
Okay, so today, as we are discussing on fluids, so fluids or vasopressor responsiveness, what are we actually looking for in critically ill patients? So coming to the latest definition of sepsis as the dysregulated host response to infection. And what is the dysregulation basically? It's the changes that occur at the microvascular and at the cellular levels. So what are the specific changes that occurs at the microvascular and cellular levels? There is diffuse activation of inflammatory and coagulation cascades, as well as there is vasodilatation and vascular maldistribution. And as discussed in the last lecture, there is diffuse capillary endothelial leakage, and there is dysfunctional utilization of oxygen and nutrients at the cellular level. So, little bit about the types of volumes that we have. In our body, we have two types of blood volume. One is the stressed volume, and the other is the unstressed volume. So, coming to what is unstressed volume, it is the blood stored in the large capacitance veins, and it does not contribute to the venous return. And it is defined as the volume in the vascular system when the transmural pressure is 0. So, and the stressed volume, it actually contributes to the cardiac preload, and it contributes directly to the venous return. And by definition is the volume of blood in the vascular system that must be removed to change the measured transmural pressure to 0 transmural pressures. Now, there's a term called hypovolemia. We all are very well aware with different hypovolemias. Now, there is something called compensated hypovolemia. And what is uncompensated hypovolemia? Basically, compensated hypovolemia, when there is a loss in the blood volume, it is the unstressed volume, which is there in the large capacitance vessels, which compromises, and there is a shift from the unstressed volume to the stressed volume, thereby maintaining the body's physiology to maintain the cardiac preload and the cardiac output. But when more volume is lost, these compensatory mechanisms become insufficient and resulting in uncompensated hypovolemia. By uncompensated hypovolemia, we mean that although there is shift from the unstressed volume to the stressed compartment, but then it is not able to augment the cardiac preload and the cardiac output subsequently. Then in sepsis, there is something called relative hypovolemia. That means the unstressed volume is increased, leading to decrease in the stressed volume. So this is what happened in sepsis. And then there is something called central hypovolemia. when the cardiac preload is decreased and cardiac output is decreased, the covering term is called the central hypovolemia, which may be due to uncompensated or relative hypovolemia, both, but also impaired venous return due to increased intrathoracic pressure in patients undergoing positive pressure ventilation. Now, making the topic more clear, if we see here, this is the normal compartment, that is, this is the unstressed volume and this is the stressed volume. This stressed volume actually contributes to the venous return to the heart, that is a preload, and ultimately the cardiac output. Now, as we just discussed, what happens in compensated hypovolemia is that as there is loss of volume, the unstressed volume decreases. That is, this part has decreased, compensating the stressed volume. So there is no difference in the stressed volume, maintaining the cardiac preload. This is the cardiac preload and maintaining the cardiac output. So this is a compensated hypovolemia model in which the fluid that is augmented is the stressed volume and the fluid which decreases is the unstressed volume. Now, from our last discussions, we have discussed that is the unstressed volume which is lying in the large capacitance vessels. So it is not exactly contributing, but as the body's physiology, there is a paradigm of shift from the unstressed compartment to the stressed compartment in cases of compensated hypovolemia, leading to maintenance of the cardiac preload and the afterload. Now, when the volume that is lost is increased to a greater extent, to the extent that the unstressed volume decreases and tries to compensate with the stressed volume, but not to that extent so as to increase the cardiac preload and the cardiac output. So in cases of uncompensated hypovolemia, what happens is that the unstressed volume tries to compensate, but there is no increase in the cardiac preload or the cardiac output. And in vasodilatation, as we have seen in sepsis, there is relative hypovolemia, which I just discussed in my previous slides. There is diffuse vasodilatation. So there is a huge increment in the unstressed volume, and the stressed volume remains the same. So as a result of which the cardiac preload decreases and the cardiac output decreases. So this is the pathophysiology of sepsis, in which the unstressed volume increases. It tries to compensate for some time, but when there is diffuse vasodilatation, as we discussed in the first slide of the pathophysiology of sepsis, that there is diffuse vasodilatation. So it is the unstressed volume which is increasing and which is not contributing by any means to the cardiac preload or the cardiac output. Now, coming to the Surviving Sepsis campaign, the latest guidelines of the 2021 section. If we see closely, for patients with sepsis, we initially had very strong recommendation for fluids, like 30 mils per kg in the initial 3 hours. That was there. Even there was a range of 15 to 45 mils per kg, and we used to give fluids till the body was responsive to fluids. But according to the latest guidelines, the recommendations have come down from strong to weak evidence and with a low quality of evidence. The sepsis guidelines are recommending that the initial resuscitation from sepsis and sepsis-induced hypoperfusion, we need to give at least 30 mils per kg of crystalloids within the first 3 hours, but the level of evidence have come down. Now, why is it like this? We all know that fluid administration is frequently the initial response to the indicators of tissue hypoperfusion. That is the general consensus, and that is what we have been doing since we have been in critical care. However, what not a lot of people understand, that it is likely that only 50% of hemodynamically unstable ICU patients are volume responsive. Coming to the Starling's curve, as we all know that if we are on the steep part of the Starling curve, then an increase in the preload is going to increase the cardiac output. But in cases of failing heart, where the graph becomes more flatter, if we are on the flat part of the graph, in a failing heart, this graph, the steep part would generally decreases and the flat part increases. So it follows a trend something around like this. The increase in preload is not going to give us an increment in the cardiac output to the extent that we would have liked in a properly functioning heart. So this is the physics why in cases of a failing heart, our increase in the cardiac preload does not contribute to the cardiac output. Now, in ICU, we have been following various static and dynamic parameters whenever we give fluid resuscitation to all our patients. We have particular standard and target endpoints that we see for any fluid resuscitation. So before, we used to see all the static parameters like CVP, pulmonary artery occlusion pressure, IVC diameter, collapsibility index, and the distensibility index, along with end diastolic volume and corrected flow time. Subsequently, we came to the dynamic parameters, and we thought that these parameters are more accurate in guiding our fluid resuscitation in cases of septic patients in ICU, such as the pulse pressure variation, the stroke volume variation, or the plethysmographic variability index. And there was always this passive leg raising test and mini fluid boluses, which help us in determining how much fluid to resuscitate in a septic patient and when to end. But are these parameters accurate enough to actually decide on patient's bedside that our fluid resuscitation is adequate? Now, coming to this study by Paul Merrick, does the central venous pressure predict fluid responsiveness? According to this study, there was no data to support the widespread practice of using CVP to guide fluid therapy. Coming to other dynamic tests that we commonly do, what are the major limitations? If we see the limitations, pulse pressure variation and the stroke volume variation, it cannot be used in a spontaneously breathing patient. And cardiac arrhythmias, low tidal volume, lung compliance. After the, as in ICU, most of the patients will have either ARDS or cardiac issues, so arrhythmias are pretty common. And after the ARDS net strategy that we used to follow, low tidal volume is most frequently used in all the ARDS ventilation strategies. So all these are limitations where the sensitivity and the specificity of these dynamic parameters, they limit. Similar is the case with inferior vena cava diameter variations, that is the collapsibility index and the distensibility index. Even that cannot be used in cases of spontaneously breathing patients, low tidal volume, low lung compliance. In cases of superior vena cava diameter variations, we need a transesophageal Doppler, which is again cumbersome to use on a bedside. And it cannot be used in a spontaneously breathing patients, low tidal volume and lung compliance. Although, and the sensitivity and the specificity decreases in all spontaneously breathing patients. Now coming to passive leg raising test, where we require a direct measurement of cardiac output, it requires a lot of expertise to actually measure the 10% increment in the velocity time integral after the auto transfusion. And expiratory occlusion test, again, it cannot be used in non-intubated patients. It cannot be used in patients who interrupt a 15 seconds respiratory hold. Mini fluid challenge requires a precise measurement of the cardiac output. So these are all the limitations that we have with both the static and the dynamic parameters that we use while fluid resuscitation. Now, how valid is IVC in ICU? The recent data that we have indicates that the volume responsiveness can be predicted with similar accuracy for spontaneously breathing. The pooled sensitivity, according to this study, was found to be around 71%, and the specificity was 81%, which is decent enough. And for mechanically ventilated patients, it was more or less slightly on the higher end with a sensitivity of 75 and specificity of 82%. Now, fluid challenge. Again, the same, whether the conditions where the pulse pressure and the stroke volume variations are less reliable, as we just discussed, spontaneously breathing patients, cardiac arrhythmias, low volume, low compliance, open chest, increase in the intra-abdominal pressures, very high respiratory rate, and right heart failures. Now, conditions where the reliability of pulse pressure variation and stroke volume variation are decreased and are quite common in ICU. Most of the patients will be under low tidal volume strategy. Most of the patients will have cardiac arrhythmias, low lung compliance. And particularly true today, since patients are less sedated and low tidal volume ventilation is more common than before, and since cardiac arrhythmias are not uncommon in an ICU setting. And a recent prospective study reported an incidence of 17% of instances where the reliability of pulse pressure variation and stroke volume variation could be used without limitation. So that's significant. Now, from the Andromeda shock trial that was published in JAMA, we came up with something, the capillary refill time, and which we measured with a glass microscope on the right index finger. And it was observed that any capillary refill time of more than 3 seconds was abnormal. And when it was compared with lactate clearance, it was found to be good enough. Now, coming to large-scale interventional trials investigating goal-directed therapy, they did not directly address the amount, timing, or guiding the clinical variables beyond central venous oxygenation. And whatever 1-hour bundles, the recommendations of 30 ml per kg of IV crystalloid to patients with suspected sepsis, within 1 hour for hypotension or lactate level greater than or equal to 4 micromoles per liter. Now, these trials, even if we see the Surviving Sepsis Campaign 2021 studies, what we found is that the definition of optimal fluid therapy, like a recommendation stands between anything between 15 to 45 ml per kg in the initial 1 hour, in the initial 3 hours. But then what is the optimal fluid therapy? There's a lot of clinical dilemma in guiding the optimal fluid therapy. So, and whatever static and the dynamic parameters we do have, even their sensitivity and their limitations are there. Now, coming to analysis of large databases, there may be a U-shaped response curve where limited amounts as well as large amounts of fluid administration are associated with worse outcome. Now, what are the worst outcomes? So whatever studies that we had initially regarding fluid resuscitation, are they obsolete? Is EGDT, process, promise, and arise, how clinically valid they are in the current clinical setting? So coming to the earlier studies by River et al. In 2001, that is the early goal-directed therapy in the treatment of sepsis and septic shock, they found that compared with 6 hours hemodynamic goal-directed resuscitation protocol with the usual resuscitation, there was a significant mortality benefit with early resuscitation. Later on, when the subsequent studies such as the ARISE trial from the L.N.G group or the PROMISE trial from England and the PROCESS trial from US, they came up, they found that the usual care was as good as early goal-directed therapy. So the PROCESS trial from the US came in, and then this ARISE from the L.N.G came in. And by 2015, the other trials came in. And coming to the PROCESS trial, in the PROCESS trial, what they did is they took some 1,341 patients, and they were all ED patients. To remind you that most of these studies, they have been done in an emergency department setting and not in a critical care setting. And we are trying to implement most of the results in a critical care setting. So what they did is 439 patients were taken along with protocol-based EGDT, and 446 patients were given standard therapy or the usual care. And 16-day mortality was not different between the 3 groups that we had. Coming to the ARISE trial, the L.N.G group, they took some 1,600 patients, and their 90-day mortality was not different between the 2 groups. And even in PROMISE trial, they could not find a significant mortality benefit, and there was no difference in organ support or the length of stay among the 3 groups that they studied. So coming to vasopressor responsiveness. So we discussed regarding fluid optimization, fluid resuscitation, and all the landmark studies that have been directing us to guide our fluid therapy and the standard parameters, the static and the dynamic parameters of guiding our fluid therapy in ICU. But are those parameters accurate enough? We have seen the limitations and we have seen the problems in ICU. So what can be done a part of fluid therapy? So according to this study, some have proposed that early vasopressor administration in sepsis may help to limit the fluid resuscitation by counteracting the sepsis-induced venous dilatation. Now, venous dilatation increases the unstressed volume at the expense of stressed volume, as we discussed in the previous slides. And vasopressors may help us to redistribute volumes by constricting the capacitance veins, that is, by decreasing the unstressed volume, by augmenting the stressed volume, and increasing the cardiac preload and the cardiac output. Now, data from 50,000 patients demonstrated that delay in fluid administration was not associated with an increased risk of death. Now, that's a huge data coming in. And another study published in JAMA in 2018, they suggested that out-of-hospital fluid administration during transport by paramedics is associated with an improved outcome in hypotensive patients. And out-of-hospital fluid administration has not been associated with and it may even be associated with increased mortality in normotensive patients. So this is really important that, in fact, some studies have said that the fluid resuscitation which have been done out of hospital and the ED settings have been sufficient enough. And in a critical care setting, the use of early vasopressor use has been found to be more useful than gross fluid resuscitation. Now, coming to the impact of fluid balance in our body, this study from Fadi also, he suggested that at least 1 day of negative fluid balance achieved by the 3rd day of treatment may be a good independent predictor of survival in patients with septic shock. Again, this study coming from Upadhyay et al., he concluded a positive fluid balance at day 1, day 2, and day 3, and cumulatively from the onset of hospital admission was associated with ventilatory weaning failure, that is, prolonged requirement of mechanical ventilation. Widman et al. Published this in N.E.J. in 2006, in which he concluded that increase in the cumulative fluid balance on days 3 through 7, it was correlated with prolonged use of mechanical ventilation, and increase in the cumulative fluid balance through 2nd to 7th day corroborated clearly to a longer ICU stay. And higher cumulative fluid balance on days 3, 4, and 5 was associated with increased ICU mortality. This result suggests that short increase in the cumulative fluid balance may have a negative influence on the clinical outcome in critically ill patients. And Dr. Malbrain, your study from 2014, that is the global increased permeability syndrome, that is the high capillary leak index, the ratio of C-reactive protein over albumin, and you suggested that the three hit model that is there in cases of GIPS, that is the first hit, that is acute injury or insult, in which suppose a pneumonia causing a sepsis, that's the first hit. And in the second hit, there is multi-organ dysfunction syndrome, that is ischemia, reperfusion, toxic oxygen metabolite generation, cell wall and enzyme injury leading to loss of capillary endothelial barrier function. And the third hit leading to global impaired perfusion syndrome. And what are the effects that we have? If we see respiratory wise, we are getting pulmonary edema, pleural effusion, alteration in the lung elastance, decrease in the PO2, increase in the PCO2, decrease in the PF ratios, increase in the extravascular lung water, the lung volumes decreases, prolonged requirement of mechanical ventilation, difficult weaning, and increased work of breathing. So this is what fluid is actually doing to the whole of the respiratory system. Not only the respiratory system, coming to the hepatic system, hepatic congestion, cytochrome P450 activation, increase in the cholestasis, impaired synthetic functions. Even in the GI, we have ascites, gut edema, malabsorption. There's a decrease in the bowel contractility, leading to decrease in the success of the enteral feeds, increase in the intestinal permeability, increased bacterial translocation. And in the CNS part, there is cerebral edema, impaired cognition, delirium, leading to more and more ICU-acquired delirium, raised in the ICP, decrease in the cerebral perfusion pressures, increase in the intraocular pressures. Similarly is the case with the cardiovascular system. There's myocardial edema, conduction disturbances, more arrhythmias. Renal-wise, we have got interstitial edema. So the takeaway point is that the fluid that we are using initially in all our septic patients, are they doing the good that we are anticipating, or they're doing more harm than good? And what we are chasing actually. And does the use of vasopressor early in the resuscitation is going to change the course of management, or is going to change the outcome in cases of mortality benefit, or in cases of patient outcome? So this was a study done in Bangkok-based a tertiary care hospital. That is early sensor study. In that, they found that the resolution of shock was pretty better in the patient subgroup in whom early vasopressor were used. It is early norepinephrine were used. If we see here, the standard treatment and the early vasopressor treatment, the achievement of control of blood pressure, tissue perfusion was far better in the cases of early vasopressor group as compared to the standard treatment group. And the duration by which the vasopressors were started after the patient was admitted in ER was around 90 minutes, whereas in the standard treatment, it was around 190 minutes. And if we see here, in how much patient we achieved the target mean blood pressure, urine output, and lactate clearance by 6 hours, it was around 48, that is, and it was only around 27 patients. And the patient who achieved target mean arterial blood pressure and tissue perfusion by 6 hours was again almost quite significant in the early vasopressor group as compared to the standard group. And even if we see the survival rate, the early group had significant advantage over the standard group. Now, what were the takeaway points from the sensor study? The median time from the ER arrival to norepinephrine administration was significantly shorter in the early NORAD group than in the standard group. As I told you, 90 versus 190 minutes. So that was a significant difference. And they found that the shock control rate by 6 hours after the initiation of resuscitation was higher in the early NORAD group than in the standard group. That is almost 76% versus 48%. Now, is the use of early vasopressors correct in cases of sepsis and septic shock? Some animal studies, such as the rat model of endotoxic shock study, they demonstrated that norepinephrine administration at the early stage of endotoxic shock improved the mean arterial pressure, aortic blood flow, and sustained mesenteric blood flow. Other studies who came up with some evidence of early vasopressor use in septic shock is this retrospective study on a patient cohort with early norepinephrine administration revealed a shortened time to blood pressure goal achievement and favorable mortality outcome. Again, this study coming in critical care 2014, they suggested that a cohort analysis of patients who underwent septic shock resuscitation. This showed a mortality advantage from early NORAD administration and illustrated the effect of delayed use of this agent. So, what is our ultimate goal? When we talk of fluid responsiveness, is it actually fluid responsiveness that we are talking about, or it is something else? Now, coming to all the evidences that I have put forward, I believe that it is not the fluid responsiveness that we are targeting. It is the preload responsiveness that we are targeting, because the ultimate target is the cardiac output, which is again dependent on the preload. So giving fluids rampantly is going to cause a lot of harm, as we discussed throughout the presentation regarding the increased ICU mortality, prolongation of the mechanical ventilation regarding the Gibbs syndrome. And are we lagging something? Like even the surviving sepsis guidelines have given us a slight hint that the level of evidence that we are finding by fluid resuscitation is coming down. And moving forward from EGDT towards process, arise and promise, we understood that the usual care was as good as the early goal-directed therapy that we followed. Also, if we see the stressed and the unstressed volume model, the vasopressors are doing the same work for us by increasing the preload by a different mechanism of decreasing the unstressed volume and increasing the stressed volume, thereby increasing the cardiac output. So actually we are checking on the preload responsiveness to changes in the cardiac output rather than fluid responsiveness. And preload responsiveness can be checked even with vasopressors. And I think the word optimal therapy, as used by the Surviving Sepsis Campaign 2021, that stands ahead, that optimal fluid along with early use of vasopressors should be the call of the hour as of now. And we need to take a call regarding when to stop the fluids and how early should we start the vasopressors. So with this question, I would like to thank you all for a patient hearing, that when are we ready to start on the vasopressors, and is the word fluid responsiveness that we have been using it since so long, is it actually fluid responsiveness or is it preload responsiveness? So with this question, I would like to thank everyone for the patient hearing. Thank you.
Thank you so much, Rajesh, Mishra. For time's sake, we move on to the last lecture, and I think afterwards we're going to have some very interesting debates. So it's my pleasure to introduce Dr. Adrian Wong, who is a consultant in anesthesia intensive care since 2015 and currently consulted at King's College Hospital in London. Within the field of ultrasound, he has interest in training and accreditation, measurements of organ perfusion, and right heart imaging. His other research interest includes clinical governance, safety, medical education, burnout well-being amongst medical professionals, which is more than actual with the COVID pandemic. He's member of the Intensive Care Society FUSI Committee, sits on the ESICM Executive Committee, and is also a member of the Executive Committee of the International Fluid Academy. Dr. Wong, please let's hear us the future of fluid therapy in critically ill patients. It's going to be a fascinating talk, I'm sure.
Thank you very much, Professor Malbrain, who's a friend and colleague and mentor. I'm just going to confirm that you can hear me and you can see my slides. So my talk today is on the future of fluid therapy in the critically ill patients. And it's fortunate that I'm going last because I'm going to pick on a couple of themes that were mentioned by our previous two colleagues and challenge them a bit for the sake of discussion. So in approaching the preparation of this talk, and I think in order to guess what's going to happen in the future, we got to realize what we don't know now. Where are the gaps in our knowledge when it comes to fluid therapy in the critically ill? And that's why I said it's quite nice to be the last speaker, because I'm going to be touching on elements from the previous two. So rule one, fluids are drugs. I don't think I need to convince this audience that fluids are drugs. And like all drugs, they've got their indications, they've got their contraindications. You've already heard about the harm too much fluids can cause. They've got their appropriate dose, they've got the appropriate infusion rates, so on and so forth. So fluids are drugs. But I think we take it for granted because it's so readily given. From the day all of you graduated med school or nurse prescribing, you can already prescribe fluids. Colleagues have already spoken about this, which is the phases of fluid management. I quite like the rows phases of resuscitation, optimization, stabilization, and de-escalation. The characteristics of these phases is summarized very nicely in this diagram, which happy for you to screenshot and share. But the crux of the phases, the question that sort of aligns themselves to the phases is you're asking a question: when to start fluids, when to stop fluids, when to start fluid removal, the de-escalation bit, and when to stop fluid removal. You've just heard from our previous speakers that with ARISE, PROMISE, the concept of fluid responsiveness or preload responsiveness, as he put it, what you're really targeting is the first two phases. It's about giving fluids. And the unfortunate thing is that it almost neglects the latter stages. So when do you stop it? When do you start removing fluid, de-escalating? So let's go through the different phases of fluid management and see if I can pick out what I think the knowledge gaps are, get you thinking a bit more, and hopefully frame the discussion for later on. So what's new in resuscitation fluids? Well, I think over the last few years, there has been a trend to move towards more balanced solutions and away from normal saline. So I'm sure all of you are aware of the hyperchloremic metabolic acidosis. You don't want to give too much chloride, you don't want to give too much sodium, etc., etc. But actually, when you look at the trials, saline is as good or as bad as a lot of the other fluids. And certainly there are lots of trials out there. I've listed a couple from you. Bias, I'm one of the editors on the bottom line, so this slide is summarized from there. But more recently, I prepared this slide a couple of weeks ago and already it's been up to date. So the basics trials came out. Very, very nice, multi-center, large trial from colleagues in Brazil, comparing balanced solutions, plasma light, to normal saline, or abnormal saline, as Professor Malbrain likes to call it. And it actually tried to answer two questions. It tried to answer the question of, does it make a difference in terms of balanced solution versus normal saline? But the other thing it did was look at the rates of infusion. So by the standard, you give it very quickly, 999 mils per hour, or slightly more slower in terms of the fluid challenges, 333 mils per hour. And if you look at mortality as your outcome, there was no difference between the group. Perhaps of the secondary outcomes that I think was the most interesting and probably the most relevant is this one here, which looked at the acute kidney injury requiring renal replacement therapy. So for all the thought on hyperchloremic metabolic acidosis, actually there was no difference in terms of kidney outcomes between the two groups. So the theoretical side of things didn't necessarily translate to actual patient kidney damage. Just again, summarizing the outcomes from the study in terms of the fluid rate. So if you could give it at a slower rate compared to a rapid rate in terms of the fluid bolus, it made no difference. It made no difference. The other side of question is, and not many people talk about it, is there still a role for colloid in resuscitation? I remember about a decade ago, in terms of resuscitation in my particular institution, we used gelafusin. It will be interesting to hear on the chat from all of you listening in, whether you still read colloid as part of your resuscitation technique, and if you do, whether it's a dextran, whether it's a starch, whether it is a gelatin-based solution. For what it's worth, in my institution, we almost never use colloids. Occasionally, you find some of our cardiothoracic anesthetists and cardiothoracic intensivists using gelatin just because it's there. They don't actually have strong views about it, but just because it's there, they tend to use it. I'm intentionally excluding human albumin from this conversation, but it'll be interesting to hear from you in the audience whether you're using colloids in a resuscitated manner on a regular basis. In terms of sepsis resuscitation, our previous speaker already highlighted the Surviving Sepsis campaign, which was very, very, very recently updated. most of you who follow the work of Professor Malbrain and International Fluid Academy would already know where we stand on it. And it's particular around the, I think probably safe to say, a very contentious issues of 30 mils per kilogram of intravenous crystalline fluid should be administered within 3 hours. The actual level of evidence behind this recommendation is very, very low, but yet it's still made it to the recommendations. So 30 mils per kilo in an average 70 kilogram male, and I don't know about your particular practice, almost every patient that I admit to my intensive care unit is not 70 kilograms. In fact, they are probably larger than that. So you're about to give 2-3 liters of fluid within the first 3 hours of resuscitation, irrespective of what the underlying cause of sepsis is, irrespective of what their cardiac comorbidities is, irrespective of what their lung ultrasound shows. 30 mils per kilo, 2-3 liters. Moving on to the optimization, and I thought the optimization phase lends itself very nicely to a discussion around monitors and monitors on the ICU. Again, I'll be interested to hear from the members of the audience whether how many of you use a PA catheter still routinely or regularly in your work setting. Again, reflecting on my experience at King's College Hospital in London, although we are a tertiary level centre unit, we probably of up to recent count 80 to 90 intensive care beds. We probably put in about 2 or 3 of PA catheters a month. So that's not a lot at all, given our number of beds, our emissions, so on and so forth. But we've adopted a more non-invasive approach with more echocardiography, bedside echocardiography as our monitor, in inverted commas, device of choice. Probably because we are still to the findings of the Pac-Man trial, I'm sure you're all aware of. But part of the issue of not using it very often is that skills from staff, junior doctors, and consultant colleagues, they become de-skilled. So you're not as comfortable using the PA catheter as you would previously had if you were using it on a daily basis. I'm going to talk about this bit for a bit. So our previous speakers talked about fluid responsiveness, and he's mentioned that what you're actually asking is, what you're actually describing is preload responsiveness. I think more or less they're the same thing from a day-to-day operational perspective. What you end up doing is giving a fluid challenge, be it from a passive leg raise or actually giving fluid, and you're measuring the increase in cardiac output. If that increase in cardiac output can only happen if you are preload responsive. So I think it's semantics, but fluid responsiveness is preload responsiveness in my opinion. But I do strongly feel that that's the wrong question. And the evidence I would cite for me, for that point of view, is that all the trials that my eminent colleague has spoken earlier, which is the process, promise, arise, etc., etc. I think it's the wrong question where they're asking. The vast majority of patients, when they come to the intensive care settings and who are unwell, I suspect will be fluid responsive. But that doesn't necessarily mean they need fluid. So if you take the classical setting and pathophysiology of sepsis, most septic patients are not going to be fluid deplete. You might argue, okay, if they've been unwell for a couple of days with fevers, etc., they might be a bit fluid responsive. But the pathophysiology of sepsis is vasodilation and changes in the stressed and unstressed body. So the treatment of that thing is to correct that bit with a vasopressor, not necessarily giving 2-3 liters of fluid just because they're fluid responsive. So that's, again, is my personal practice. Just because you are fluid responsive doesn't mean you need fluids. Treat the underlying cause, have a think about the pathophysiology, so on and so forth. This trial was also mentioned by the previous speaker. It is the Andromeda shock trial. In my personal opinion, the work of Glenn Hernandez and colleagues based in Chile is one of the finest most thought-provoking trials, I would say, in the last 5 years or so. And basically what they said was, instead of having using lactate and traditional monitors of perfusion, etc., to guide fluid therapy, what they did was just simply capillary refill time, using a more standardized capillary refill time, using a microscope slide. We've all done it in med school, we're taught how to do it, but I would argue that most of us don't use it on a day-to-day basis now. And what it essentially found was that the use of capillary refill time versus traditional monitor was as good, or if you look at it, as bad as more traditional markers in terms of ultimately patient outcome. And considering that a microscope slide is cost cents as opposed to lactate, which costs several hundredfolds more, if they achieve the same outcome, is it therefore offer good value for money in terms of patient investment? And this is the trial that was published in JAMA. I promise you, those who are speaking in, isn't me that's drawing lines on the talk. I think Dr. Abdul, according to my slide, is drawing on the arrows. Thank you very much for taking an interest in my slides, Dr. Abdul. But just to reassure the rest of the audience, it isn't me that's drawing on my own slides at this moment in time. As Professor Malbrain mentioned, ultrasound, I think it's safe to say that ultrasound has become very, very established in critical care practices. We use it routinely now, I would suggest, to put in vascular access, be it venous or arterial. The use of bedside ultrasound to scan the heart, the lungs, etc., is becoming more and more established. But the question that needs to be asked is, does it make a difference? Does it make a difference to patient care? Now, the benefits of ultrasound as well, you can say you don't have ionizing radiation, you don't move these patients to the radiology department, you are the clinician that will be interpreting the scan and integrating into the rest of the parameters that you are seeing by the patient's bedside. So isn't it obvious that the patient will benefit from having ultrasound as part of the care that's delivered to him or her on the intensive care unit? And the answer is, well, yes. So this is again a very, very recent trial published last year, where bedside focus during ward emergencies, so these are sort of more acute settings, was associated with improved diagnosis and outcomes, and it's an observational prospective study. Equally, this is another yes, we need to do more bedside ultrasound. This is by colleagues in China who use ultrasound to guide goal-directed therapy in septic patients. The schematics or outline of that study I've summarized is shown in that flowchart on the right-hand side of the screen. So essentially it's saying, is this patient fluid responsive? Be responsive, give fluid. If it isn't, give noradrenaline. If there's neural response, have a look at their contractile function. If their contractile function is impaired, start an inotrope, so on and so forth. Scan their lungs. If there's evidence for pulmonary edema, think about the amount of fluid you need to give. In fact, think about decreasing the amount of fluid, or indeed taking away fluid in these group of patients. And again, in this piece of work by the Chinese colleagues, it will improve patient outcome. But also, for all the evidence supporting ultrasound being a benefit, we'd find studies such as this one by Paul Atkinson and colleagues in America, where ultrasound in undifferentiated hypertension didn't improve outcome. It didn't improve outcome. And we might discuss that in the question and answer session later, and why it might be the case. Stabilization and maintenance. A lot of the times we look at patients on the intensive care units, and the longer they stay on the intensive care unit, their cumulative fluid balance, generally speaking, increases. This is just results of some very nice work from colleagues in Belgium, Niels van Rigemorten, who looked at where these maintenance fluid creep comes into play. So this is what the average patient requires in terms of water, glucose, sodium, potassium. You already know this. But what's interesting was the results of the Stockmess trial, in which they compared using normal, abnormal saline to a more hypertonic solution as maintenance fluid in patients undergoing surgery. And what they found was that it is not the resuscitation fluids that are the biggest source of fluid administration on the ICU, but rather the maintenance side of things. And that's important if you reflect on your own practice in your units. If the patient is nearby mouth or post-operative, would you automatically start maintenance fluid? And if you do, what sort of maintenance fluid are you using? Are you using a balanced solution, in which case, theoretically at least, you'll be giving too much sodium, even though it is a balanced solution? Or are you using a hypertonic solution? So which is it that you're using? Probably the biggest gap in terms of knowledge when it comes to managing fluid strategies in the intensive care unit is the de-escalation phase. And this is the last bit of my talk, when to stop giving fluid and start diuresing the patients. So what do we know about it? The when and how. This is a very, very nice piece of work from Jonathan Silverside and colleagues based in Belfast in Canada. And in this survey, what colleagues did was to survey critical care physicians in terms of what their views are and what they would do in terms of fluid management and de-resuscitation on one's given a couple of scenarios. So this is their views, and in terms of how do you perceive the issue of fluid overload in ICU patient? How important is it? I think there is a strong body of evidence to suggest, and I can only agree with my previous speakers, that a positive fluid balance on the intensive care unit beyond something like 48 hours or so is associated with a poorer patient outcome. And it's not just the mortality side of things, but also the morbidity side of things. A positive fluid balance is associated with the increased length of stay in hospital, increased time on the ventilator, decreased ability to mobilize, so on and so forth. This is just an example, a screenshot, an example of the scenarios for which the survey wanted an opinion on. Broadly speaking, this is a very stable patient still on a small dose of noradrenaline. He's very edematous now. He's 10 liters positive based on cumulative fluid balances. What would you do? And the take-home message I'd like to highlight from this survey, and it's a recurrent theme within a lot of the responses in the survey, is that there is a huge degree of variation. Huge degree of variation in terms of what colleagues thought were important, huge degree of variation in the parameters that colleagues will look at in deciding what to do, and there's a huge degree of variation in what colleagues will ultimately do, whether you diurese, whether you use a infusion, whether you use renal replacement therapy, so on and so forth. Huge degree of variation, as summarized by this graph. So variation in terms of what would colleagues do if faced with that scenario, essentially a fluid edematous patient who's relatively stable, who's been in intensive care units for more than 48 hours. Building upon that concept, for those of you who use ultrasound in your practice, and no doubt you're aware of the increasing interest in venous congestion and assessment of the venous system using ultrasound. I think it's fair to say that in intensive care, when we talk about hemodynamics, we generally talk about the arterial side, what's the mean arterial pressure, so on and so forth. More recent to that, we talked about the microcirculation and tissue perfusion, and it's only recently that the venous side of the equation in terms of hemodynamics and circulation is getting some traction, some interest. And the concept between the venous excess ultrasound score is a very, very nice one. It sort of makes sense, and I'm going to take you through it. Now, fundamentally, what it's saying is that if you've got a system that's overloaded, you will start noticing change, not just within the arterial side, but the venous side of the circulation as well. And if you access the flows using Doppler techniques in the main veins of the circulation, in the abdominal circulation, more specifically, hepatic vein, portal vein, and infrarenal veins, you will start noticing abnormalities. And these abnormalities can be put together and combined into a score to say how likely, how unlikely is this patient to have venous congestion. This is a very nice infographics from colleagues in POCUS 101. It's free, just summarizing what colleagues in Canada did. But the fundamental basis of the examination is that with increasing venous congestion, there will be increasingly abnormal flow within the main venous system in the circulation. It's all well, nice and good to talk about de-resuscitation. I like it. It sort of makes sense. We also know that a positive fluid balance is associated with poorer outcome. But actually, if you flip that coin, the evidence that de-resuscitation improves clinical outcome is extremely limited, if any. Most of the evidence that is out there in the literature tends to be in case series, case reports, so on and so forth. But there is no multi-center trial that, well, there is multi-center trial that looked at de-resuscitation and whether it improves patient outcomes or not. However, the biggest limitation of these randomized controlled trial is that it didn't achieve separation between the control arm and the de-resuscitation arm, i.e. the de-resuscitation arm has as much or as little fluid balance compared to the control arm. So you did get separation, which is why the RADAR 2 trial by the Northern Ireland Canadian colleagues is of great interest to me and should be of great interest for you as well. And what they're trying to do, they've already published the feasibility of it. So that what they're trying to do is to look at conservative fluid strategies versus early and active de-resuscitation of these patients. The feasibility trial has suggested that they will achieve separation of the two groups. So it'll be interesting to see whether that group, whether this trial would prove whether active de-resuscitation actually improves patient outcomes or not. So as a close, then, the unanswered questions, and therefore as a guide to what might happen in the future, is what fluids to give? Are we really convinced that balanced solutions are definitely the way forward? What monitors to use? The Andromeda trial suggests that capillary refill time is as good as bad as any of the fancy monitors that we get. I hope I've highlighted to you that the latter phases of fluid management, the stop giving fluid and de-resuscitation, and whether it ultimately improves patient outcomes or not, is still waiting to be addressed. I'm very happy to share the slides with anyone. Those are my email contact addresses. That's where I work. And I'm happy to take questions with the rest of the panel. Thank you very much for your attention.
Thank you so much, Adrian, for this excellent talk. I have no idea how many minutes there are left. If someone can help me, how much time do we have for discussion?
We have around 20 minutes for discussion. 20 minutes.
Okay, so I would first take some of the questions that were posted in the chat box. So for the first speaker, Dr. Srinivasan, there was a question with regard to the use of furosemide in patients with hypoalbuminemia, because we know that furosemide needs to be carried via albumin. If there is low albumin, there will be a bigger distribution volume and there will be less furosemide that will go to the proximal tubulus. So the effect, the diuretic effect, would be less. So may it be wise not to substitute the albumin in those cases?
I mean, the basic concept, as you rightly said, is that the volume of distribution of furosemide would possibly increase if the albumin levels are low, and probably the levels will not be enough at the proximal tubules for it to release. Now, but having said that, a lot of trial studies have shown that there has been no difference whether we give furosemide with albumin or pure furosemide alone with regards to clearance of excess amount of fluid. So the concept, it's a bit controversial that we always have to give albumin along with furosemide to clear fluids. It has not been supported by any large trial. In fact, a lot of study has come up which says that probably the outcome is the same. What is more important is obviously to increase the perfusion of the kidneys. So that is a more important aspect, which would probably improve the glomerular filtration rate and improve the overall clearance of fluids rather than just using albumin as an add-on to do the same. So with a lot of widespread clinical evidence saying that albumin is mandatory to be added to it along with furosemide, we can go along with furosemide alone. And as per this model, it seems to suggest that albumin per se will not serve to draw the fluid from the interstitial fluid. That's exactly what I was trying to focus upon. I wasn't focusing on whether it's going to increase the urine output or not. Eventually, what's going to do is basically, if you achieve your perfusion parameters, your renal perfusion would improve, and obviously your clearance of fluids will also improve subsequently. Right.
Yeah, thank you. It comes down to the last two lectures that, of course, you cannot start diuretic therapy if the patient is still in a shock state or with massive capillary leak or poor source control. So I think first you need to deal with that before you can even think about de-resuscitation, because it probably will work for 1 day or 2 days, but you will never achieve a negative cumulative fluid balance. I was fascinated by your talk on the revised or better extended Starling principle. And it's nice, this glycocalyx, which is a gel phase, and that helps to regulate the fluids between the intravascular and the interstitial space. But is there any way that we can monitor this at the bedside? Can we predict some of our actions to be detrimental for the glycocalyx? Like, for instance, if you give a big shot of saline, does it make any sense to give fluids in a slow infusion rather than a bolus? Can you bring some light?
Exactly. So it has been, at least, if you ask me if there is clinical evidence that whether the glycocalyx is intact or not at the bedside, well, that is something which no such evidence has been found. But yes, evidence has been found that giving large fluid boluses tends to damage the glycocalyx. Having a poor sugar diabetic control tends to damage. Smoking tends to damage. Sepsis per se, inflammatory states, all end up damaging the glycocalyx. So they are risk factors for damaging the glycocalyx, and that would attribute to the glycocalyx sieve or the molecular sieve being lost, and the fluid just rapidly filtering out from the capillaries into the interstitial space. So clinically, if you ask me, is there a way to judge it? No, it's not. We do presume that in an inflammatory state, the glycocalyx does get affected. Certain agents can reduce the disruption of the glycocalyx to some extent. But as I said, it's just a model which is still in evolution. I mean, there's more people who are trying to understand regarding to the exact role of the glycocalyx and how much and factors would probably preserve it and what factors would damage it. We know certain factors will damage it, but not all of them. But yes, avoiding excessive amount of fluid boluses would. In fact, the FEAST study from the sub-Saharan African population of malaria patients in pediatric patients, they showed that patients having large fluid boluses who were sicker tend to have higher mortality. So if we were to extrapolate that large fluid boluses can disrupt the sudden large boluses can disrupt the glycocalyx layer, well, that does come sort of fit into this picture. Why rather sustained fluid infusion would be possibly a better way to preserve it rather than giving upfront large boluses. So that's something which we still need to understand better. That's my understanding.
Thank you so much. And I'll move on to the next speaker. I will get back to you regarding albumin, because there were some provocative thoughts that you made. So, but let's now go to Dr. Mishra. Thank you for your excellent lecture. I pretty much like the differences between stressed and unstressed volume, relative and central, hypovolemia, compensated and uncompensated. But being just a basic bedside clinician, how do I measure the stressed volume and the unstressed volume? How do I know the Frank-Starling curve of a patient when he arrives in the ICU in shock? And how do I know the position on the Frank-Starling curve? So in order to understand whether fluids or presses may be beneficial or not. And what do you believe about the role, you didn't mention it, of the mean systemic filling pressure?
Thank you, sir. And thank you for your question. What I feel is that the existing dynamic parameters that we have for measuring the various responses to fluids, I think we need to integrate it with clinical parameters, not isolated parameters that we are using. Supposedly, we are doing a passive leg raising test, and we are checking a velocity time integral by directly monitoring the cardiac output. Now, every time we give a bolus, the outcome may come. A 10% variability may be there in the VTI. But then, if we see, we are just trying to fill a leaking tank. As we know from the pathophysiology of sepsis, every time we fill in the tank gets partially full and then it gets empty again. So in that sense, I feel that our fluid resuscitation should not be isolated, directed by the static and the dynamic parameters that we have been conventionally using. And we should integrate into our practices more of parameters like the false protocol. If we see the lung volume, if we see in any ventilated patients, we just see the FiO2. If the FiO2 is increasing, if we see that the lung cordons, if we see the B lines are increasing, if they were 2 initially at the initiation of our resuscitation, after giving say 20 mils per kg in the initial 1 hour, we find that the B lines have increased to almost 5 in each quadrant. I think we should take a call at that point of time. Okay, my FiO2 is increasing, my VTI, every time the increment in the VTI would be there, but then it doesn't mean that we are still on the steep part of the Frank-Starling curve. We may be at the plateau, but the heart is responsive to every bolus that we are giving. So we need to look at other parameters, a part of the dynamic and the static parameters that we look. We need to get the lung ultrasound probe on the lungs. We need to check the ventilators. We need to check the P peaks and the P plats. And corroboratively, we need to decide how early should we take the help of vasopressors rather than continuing with the fluids again and again, a bolus of 30 mils per kg, maybe 35 mils per kg. And in that way, we are just increasing the body's load of fluid, landing the patient in gyps and doing no good of the patient. And as I think in almost all the presentations, what we have seen about the harmful effect of fluids on a long run. And we can't deny that. It's 2022, and we have to accept the fact that fluids have the direction of fluids have to be optimal rather than a fixed guidelines that we are following up till now, till last year. That one size does not fit in everyone. So for every patient, the pathophysiology is different. We need to act in a different way, and we need to take the early call of vasopressors. And I strongly feel that is the time to think, because as such, what we are doing with the boluses of fluid every time, we can do the same thing by giving vasopressors. Because by giving boluses, we are increasing the preload. We are targeting that the curve would be on the steep part and we'll get an increase in the cardiac output. But it does not happen every time. And in that process, we increase the cumulative fluid balance of the patient, and we land up in a long-term worse scenario. So I think we need to integrate our variables from not only the static and the dynamic parameters, but also the other parameters like as the lung ultrasound, the false protocol. We need to integrate in each and every patient, and then we can probably guide our fluid better. We can take the call for early vasopressor use. And whatever studies we have till now, sir, most of them are retrospective studies. And I think we need more and more studies regarding them. And more prospective, more randomized, multicentric studies will be required to understand the utility of early vasopressor use. As of now, there's limited evidence, and probably we need more exhaustive studies to delineate the role of early vasopressor use.
Thank you so much, Dr. Mishra. I think we all agree that the best fluid is the one that has not been given unnecessary to the patient. So, of course, we must assess the fluid status, volemia, hypervolemia. We must assess the fluid responsiveness. Best we do this with a passive leg raise or something which creates an auto-transfusion, or it could be a vasopressor dynamic test. And then when we are giving fluids, I think by all means we should do an assessment before and afterwards, because this allows you to construct the Frank Starling curve of that actual patient. And the focus in the past may have been too much on fluid responsiveness and functional hemodynamics when they were increased, equaling you should give fluids, which obviously is not the case. But as Dr. Wong also nicely pointed out, it may not be the resuscitation fluids that cause the fluid creep, but other types of fluids like maintenance or nutrition, or the fluids that we use to dilute our drugs in, like antibiotics or sedatives and so forth. So that may even be more important. And I think to me, the most raise for caution on using these dynamic parameters is that they are affected by the ventilation settings. So basically, they are heterogenic, follow heart-lung interactions, and that was also a comment. Of course, if your ventilator settings are inappropriate with too high volumes, too high PEEP, then of course you will have functional hemodynamics that will increase beyond the 12% threshold, and we will give too much fluids to these patients. I think you nicely pointed towards one of my favorite, which is intra-abdominal pressure. And getting back to the first speaker, intra-abdominal pressure may also affect lymphatic flow. So isn't it about time that we should monitor intra-abdominal pressure as yet another vital sign?
Absolutely, absolutely. I totally agree with you. So yes, anything which sort of retards the flow of lymph and clearance of lymph and back into the main vasculature will obviously retard the clearance of edema, and obviously will affect the further flow of fluids from the to and from the capillaries. So yes, intra-abdominal pressure, yes, definitely would play a very, very vital role, and I'm sure Professor Malbrain is the best person to give the evidence regarding the same, because he's done the maximum amount of study regarding the same.
With regard to glycocalyx, what about inhalation anesthetics? Will they preserve the glycocalyx or?
Well, I haven't actually come across any such thing which says that inhalation anesthetics would penetrate the glycocalyx odor, but it just says that under anesthesia, the context sensitivity or volume kinetics of saline is different from patients who are anesthetized. The clearance of the fluid and the retention within the intravascular compartment is longer. In fact, opioids and all also reduce the lymphatic clearance. Sleep improves the lymphatic clearance. So there are a lot of factors, especially use of opiates and all, which we use routinely in our ICU setup, which can actually hamper or slow down the lymphatic clearance of extra amount of fluid.
So what about
that is also something which
albumin? Albumin may have anti-inflammatory and other
yes.
properties. So what about the continuous infusion of albumin that may be beneficial for the glycocalyx?
See, albumin is a part of the glycocalyx. Effectively, it's one of the components of the glycocalyx. Continuous infusion. I mean, see, the Albios trial, which sort of tried to give albumin and tried to achieve a target greater than 3 grams per deciliter, really didn't prove a lot of benefits. See, albumin has a role. What I would like to say is that as a volume expander in sepsis, a temporary role by increasing the colloid aquatic pressure, slight amount of volume expansion, a very expensive way of expanding the volume, yes. But eventually, over a long period of time, it's going to further worsen the edema and further cause because it's going to go into the interstitium. It has a very strong non-expanding volume expanding role in the form of an anti-inflammatory effect. Yes, it has albumin has a strong anti-inflammatory effect as well. So it forms a major part in re-establishing the glycocalyx because it is a part of the glycocalyx as well. So those roles of albumin still are important. So they are the non-volume roles of albumin, which may be still important. So albumin still has some role to play, but the way we give albumin, just to target a number, try to get it above a specific figure, or just by the thought that albumin draws in fluid from the extravascular space, that concept is what this extended Starling principle is just trying to say that probably is not the right way to go about things.
Thanks so much. I see time is running, so I would like to get to Dr. Wong regarding the results that he presented of the point of care ultrasound study in the ER that showed no beneficial effect. Could you help us understand why not? And this was an unspecified hypotension.
I think what's interesting about the early ultrasound trials, which were probably less positive compared to what us ultrasound practitioners would hope for, is that what it didn't do, it basically, most of the early trials said, right, here's an ultrasound machine, you do what you want with an ultrasound machine, and you use it. The control group is you do your usual thing. The problem with it is that the early trials at least didn't, a lot of the ongoing care treatment decisions was left at the will of the treating team. So an example of that problem is this. So you and I might do an ultrasound scan on my unit. We might agree that that ultrasound scan of the heart shows that the LV isn't working as well. And we might say, okay, we need to treat the dysfunctional LV. Professor Malbrain, you might go, I'm going to use levosimendan. I might say, well, actually, it's not that bad. I'm going to use good old-fashioned dobutamine or Mirano, etc., etc. So the trial design wasn't really asking the right questions. I think if the trial design was saying, would the diagnosis be reached earlier, I think ultrasound would definitely win. But to just say ultrasound resuscitation without controlling what people do with it, I think it's a bit more complex to ultimately influence patient outcomes at the end of it. There's a saying that a fool with a tool is still a fool. The ultrasound is just another tool that we use. It's what you as a clinician by the bedside being able to integrate all the other information and then deciding what to do with all this information is probably the most important bit.
Fully agree, and I think that their ultrasound may have a role in setting the limits or the starting point for de-escalation and maybe fluid removal with the venous congestion score and so forth, or the absence of inferior vena cava collapsibility and things like that. So the absence of fluid responsiveness, because the normal thing, you and I, we are all fluid responsive as we speak. I hope, if we have a good functioning heart.
Definitely. I think that's why I think I put it in the answer in the chat. I think whether the patient is fluid responsive or not is probably the wrong question to ask. And whenever I scan now, I've noticed a change in my mindset. I put my hand up and said before I was scanning for fluid responsiveness, but now I sort of consider it fluid tolerance. Will this patient tolerate the fluids? It doesn't necessarily imply that I'm going to give it, but I know where that person sits in a rough schematic of the Frank-Starling curve. They should be, all of us should be somewhere on the steep part still. That's where we're designed to function. By the time you get to the top bit, where the flat bit is, you've missed the boat, I think, in a lot of our patients.
Yep. And I think to me, the bottom line is that much we don't know actually. And the so-called big pragmatic fluid trials, if you look at the volume of study fluids that were examined, it's only 1 liter or 2 liter given in 1 day or 2 days or even a whole week. And then I don't think it makes sense to draw any conclusions of that. And from burn resuscitation, we know that saline is not a good option.
Agreed. And I think that's one of the biggest limitations of the balance trial, which I quoted, and the plus trial, which has just come out, is that they actually gave very little fluids, very, very little fluids. So it's no surprise that they didn't find the outcome work.
Yep. Exactly. Are there any questions from the audience? I think there was a question, okay, what is a normal CVP? What is a normal blood pressure? Anyone want to give a comment on that?
I'll be perfectly honest with you. I don't look at CVPs very often in my intensive care unit. We hook it up. I may notice it when it's very, very high. If it's very low, I'm meaningless. Any number in between more than 15. Most of the time, my nursing staff attach the CVP to give infusions down rather than monitor per se. So if it's more than 15, I start maybe noticing it, but otherwise I don't. I think it's probably more useful if you're going to use it to look at the actual waveform with it, in the same way as the Doppler techniques for the big veins, hepatic portal, probably means some things, but we don't use it as often now. We use other things.
Okay. Anyone using systolic pressure variation, which from a theoretical point makes sense? So you have blood pressure variations, then you go for apnea, and you can see a delta up and a delta down phenomenon. And only the delta down phenomenon would be mirroring fluid responsiveness. I have no clinical experience with it, but from a theoretical point of view, makes sense. And then there was a question regarding heart-lung interactions to establish fluid tolerance, let's sort of speak. I think there has been this publication on the respiratory systolic variation test. So if you gradually increase the tidal volume, you will see the changes in stroke volume variations, and this you could construct a Frank-Starling curve and identify the slope of the curve. Can passive leg raising test be done on both spontaneous breathing and mechanical ventilated patients? It's a question from the audience.
I've typed something. Our friend and colleague Xavier Manier and Jean-Louis Tabou have published work on that already. Okay. And if you believe their work, they would argue that the passive leg raise could be used for spontaneous breathing patients. I think there are, from my personal view, is that there are limitations to that. But if you believe their work and they've published on it, and yes, you can also use the passive leg raise and fluid responsiveness in patients who are not necessarily in sinus rhythm as well. And that's the work from Xavier and Jean-Louis.
Yeah, absolutely agree, but there may be some misconceptions that not all patients where we perform a passive leg raise test do have a continuous cardiac output monitor. So by definition, you need to have an increase in stroke volume by, let's say, 10%. Sometimes we just look at the increase in systolic blood pressure or mean arterial blood pressure, but there this may not hold true for patients who have a poor left ventricle or diastolic dysfunction or systolic hypertension and rigid arteries. There you will see an increase in pressure, but those patients are not fluid responsive. So, okay, if no one stops me, we can continue discussing because I really enjoyed this. But I think it's about time, and I hand over to the president of the session, or the chair, Dr. Reshma Tewari and Dr. Saurabh Kumar Das.
I thank all the audience for making this event success. I thank all the speakers, Dr. Adrian, Dr. Srikanth, and Dr. Rajesh for their fantastic presentation. I'd also like to thank Professor Malbrain to take out some time from his busy life to moderate this session. And by saying this, I'm going to wrap up the session here. Hope we'll meet with another session in some coming months. Thank you. Good night.
Thank you very much, everyone. Stay safe. Thank you. Bye.
Thank you, sir.
Bye-bye, everyone.
Bye.